Good evening, everyone. My name is Beverly Cunningham, and I greet you in the wonderful name of Jesus. I am the lead for Aberdeen Street Health Foundation, and just like to welcome everyone that has taken the time out to join us this evening for the third Friday Focus seminar, focusing on COVID-19 and the impact on the BAME communities. Firstly, just to reiterate some of the seminar etiquette guidelines that you saw on the welcome slides, we've asked that you ensure that your device reflects your name for security reasons. Please keep your audio on mute at all times, unless you are invited to speak. And in terms of questions, we have had some pre-questions, but throughout the presentation and this evening, if you'd like to pose a question, please do that on the chat facility. Tonight, the seminar is not going to be live streamed. It will be recorded, and then it will be placed upon social media afterwards. Before we carry on though, as people of faith, we are Christians in Ash Foundation, and we always ask the Lord to be with us and guide us throughout whatever we do, and we will do the same this evening for this seminar. So I will hand over now to Sister Lorna Campbell, who will open in prayer. Thank you. Sister Lorna.
Good evening, anyone. Everlasting Father, we come before you thanking you for keeping us safe thus far. We trust you to see us through these difficult times. Death and the pain of bereavement is all around, and people are lamenting. But death holds no secret from you, because you are acquainted with our grief. This evening we come in this series of Friday Focus with the topic of the respiratory system. We acknowledge you are the breath of life, and without breath we perish. Let the words spoken this day be words of wisdom, and help us to understand and to take on board sound counsel. We thank you, Lord, for our invited guest from the medical profession, who has given his time freely to speak to us. Lord, we appreciate him, and we ask you to continue to bless him in his work. Grant us wisdom to put into practice, Lord, the good advice, and to take care of ourselves better. We confidently trust you to continue to take care of us. Hear our prayer and bless us all in your holy name. Amen.
Thank you for that prayer, Sister Lorna. Okay, so some of you that haven't joined us over the past 2 weeks, and you're wondering who Ash Foundation are. So Ash Foundation stands for Aberdeen Street Health Foundation, and we worship at the Church of God of Prophecy in Aberdeen Street, Winson Green. And the group, there's approximately 11, last count, 11 of us in Ash Foundation, and we work within health and social care, some in teaching, and some with really good administration skills. And we saw a need to support the church congregation and the local community in terms of maintaining good health. So that's who we are. And at this time when coronavirus, COVID-19, has just taken us all by surprise, the whole world, we saw a need that as a group of faith people with a huge congregation base, that we should do something different and try to make an impact locally at this time. And we've collaborated with Birmingham City Council and also a nutritionist from My Nutrition, Yvette Besley, and also Birmingham Community Healthcare NHS Foundation Trust, they're a community trust we're local at Aberdeen Street to the Community Trust in Winson Green, and approaching the trust and discussing with them what we felt that we could do and collaborate together. It was an immediate yes, and I really thank Birmingham Community Healthcare NHS Foundation Trust, my colleagues in the trust, Tom, who is here tonight, Tom Avent from the Respiratory Service. Tom is a clinical lead on the Respiratory Service, and he's going to be presenting COVID-19 and the respiratory system for us this evening. So I really thank you for that, Tom. I will hand over to you shortly. I did also notice Dr. Sonny Kelsey Lilico, I hope I've got your surname right, Dr. Sonny, who's also joined for support. That's fantastic. And on the 5th of June, we'll be hearing from Dr. Sonny. I'm not quite sure if any of our other colleagues have joined us as yet. If you are there, hello and welcome. I will have a look later on. Well, this is the third seminar in a series of 6. The first seminar, we focused on ourselves, in individual bodies and our nutrition, and we heard from Yvette Besley, and we were given a lot of advice, really beneficial advice to strengthen our own built-in army. Last week, we were joined by Dr. Justin Varney, Director of Public Health, Birmingham City Council, and Councillor Paulette Hamilton, and they talked us through coronavirus and how it's affecting the world, and in particular the Black, Asian and minority ethnic community. And we've also had an update from Dr. Varney, and we'll go through that towards the end of this seminar. The update is following the change in advice that came out on Sunday from the government. So yes, as Christians, we're hoping that this model can be replicated with other faith groups, and have that link with the faith groups and NHS health, and also public health and the council, and work together and collaborate for the good of everybody, really. So I'm not going to carry on for much longer now. I really want to hand over to Tom Avent, who is here from Birmingham Community Healthcare NHS Foundation Trust, Respiratory Services, and I will hand over to you, Tom, if you're there. Are you there, Tom? I know you've come in.
Hello, can you hear me?
I can hear you now. I'll hand over to Tom. Thank you very much.
Smashing. No, thank you, Bev, and thank you, Lorna, for a wonderful introduction, actually. It was lovely, nice to see everyone here, so many happy faces on a Friday evening. So I've got a presentation to share, so I'll just share the slides now, and hopefully you can see them. So bear with me while I load it up. Hopefully that will come through. Can everyone see that okay?
Yeah, that's fantastic.
Lovely. So what I'll do during the presentation, I know everyone's on mute because you get feedback, but I'll go through the presentation and I'll pause for any questions. We have received some questions already, so I'll do my best to answer those to the best of my ability. But if you want to ask questions as we go along using the chat facility, then we can have a look at that as well, okay? I'm just going to bring it across here. Okay. So, acknowledgements before I start. So, a lot of the information, because it's written really nicely, it's really easy to read, gives everyone a nice clear picture. I've got this presentation from the British Lung Foundation. And in terms of the questions, for any medical support, I've contacted Dr. Raja Ramachandran, who's a GP with specialist interest in respiratory, and also the respiratory clinical lead for Birmingham Solihull CCG. So we'll run through the outline of the session tonight. So hopefully give you a little bit of introductions to COVID-19 and what that means to the respiratory system. I'm not going to go into too much detail because I don't want to go into rounds and rounds of depth and lose you all, but hopefully give you a summary. Look at COPD, have a look at asthma, and then hopefully help you to manage your own condition should you suffer from COPD or asthma, and manage your symptoms, and then finally come to a question and answer to hopefully support anyone who's struggling at the moment. So a little bit about me to begin with. So I'm a physiotherapist by background, worked in healthcare for probably far too long, just over 10 years now. And I specialise in respiratory, worked across most of Birmingham hospitals, to be honest, so Heartlands, Good Hope, Solihull and QE. Didn't venture as far as City and Sandwell, and ensure the bright lights of the community to join Bev to manage the respiratory team there. And my team support people in the community with long-term respiratory conditions of asthma, COPD and bronchiectasis. We've got 3 main branches, so that's domiciliary visits, which predominantly is around the area where I believe the church is based. So we used to be based out of Lansdowne Road, and now we've moved to Nineveh House. So we do lots of our home visits based from patients that get discharged from City Hospital. We also run primary care clinics with the support of Dr. Ramachandran, and one of our other areas which is expanding all the time is pulmonary rehabilitation, which we'll have a look at shortly. So, COVID-19 and the respiratory system. So what is COVID-19? So it's a common virus that causes infection in your nose, sinuses, or the throat, or upper throat. Most coronaviruses aren't dangerous, and it comes from a large family of viruses with illnesses ranging from the common cold to, unfortunately, more severe diseases. A novel coronavirus, as they call it, nCoV or COVID-19 strain, is a new strain that up until now had previously not been identified in humans. It can cause symptoms from a respiratory point of view in your upper respiratory tract, which is your sinuses, nose and throat, or your lower respiratory tract, which is your windpipe and your lungs. Fortunately, most people who come into contact with COVID-19 will only have very mild symptoms. Unfortunately, like most conditions like seasonal flu, for example, elderly people and people with long-term health conditions are most at risk. This is because as you age, and if you already have underlying health conditions, you've got a weakened immune system. Pneumonia and complications relating to pneumonia are the most common cause of death with COVID-19. And I'm aware, and there's some discussions last week, that members of the BAME community are more at risk. And there's ongoing research into why that is at the moment, which is interesting. So hopefully we can help you to support your long-term respiratory condition this evening. So a little bit of anatomy, first of all. So how do we breathe? So breathing in is active. So when we breathe in, what happens is our lungs expand. So we take a big breath in, the muscles in between our ribs contract, and the big one there with the arrow that you can see on the screen, our diaphragm, that moves down. That lowers the air pressure inside the chest and draws air into the lungs. So breathing in is active. So you have to put some effort in to breathe in. What happens then is the air goes down your windpipe, so the big bit in the middle here. So in through your nose, in through your mouth, however you breathe in, goes down to the back of the throat, into your windpipe, and then divides into your right and left main bronchus here. It then passes down lots and lots and lots of airways, a little bit like the branch of a tree. So as a tree, you've got the main trunk, and it divides off into separate branches, and you've got much more smaller branches coming off that, and finally you get the leaves at the end. Well, the leaves at the end from the respiratory system are tiny air sacs called alveoli. These are really, really important, and actually they're really, really clever. So if you were to unfold your lungs, pretty impossible to do, but if you were to spread your lungs out, for example, the actual surface area of your lungs will be the size of a tennis court. So that's the amount of area you've got there inside your lungs for gas exchange. Yeah, it's really, really clever. So they're tiny, tiny air sacs here. I'll just hover my mouse over them so you can see. Lots of them there, and there's millions of these in the lungs. All around those tiny, tiny air sacs, you've got blood vessels called capillaries, and they're really, really thin, almost like paper thin, 1 cell thick, and they allow oxygen to go into the bloodstream and go around the body to feed the organs, and they allow waste gases, so carbon dioxide mainly, to leave the lungs, and then when you breathe out, you get rid of the carbon dioxide. Okay. That in a nutshell is how we breathe in, how oxygen gets into the blood and how carbon dioxide escapes. Okay, and then we can move down to breathing out. Breathing out is the easy bit, it's passive. So if we're feeling tired, had a bit of a rough day, and you have a big sigh out, it feels quite nice. So you're passive. So what's happening is the muscles that you've used to lower that air pressure into the chest and draw air in, they're now relaxing. So your big muscle involved with breathing, your diaphragm, that moves back up, and the muscles around your lungs, your intercostal muscles, they all relax. They squeeze the chest together, and that forces the air out of the lungs. and then you repeat the cycle again when you breathe in. Just flicking back aside in relation to COVID, what can happen in the more severe cases of COVID, and I must stress this is very rare, we're talking, you know, less than 1% of people who come in contact with the disease, is that you can have a very nasty pneumonia. And unfortunately, as a result, your body gets overwhelmed by the infection, and your tiny, tiny air sacs here, they become filled with fluid. Now, obviously, that creates a problem because you can't get any oxygen into the body, because the normal way of getting oxygen into the bloodstream is blocked by this fluid. Okay, and that's why you see people on ventilators there, because you're using the ventilator for support. Okay. So before I go on to the next section, has anybody got any questions there at all? No?
Hello,
Hello?
can you hear me?
I can, yeah.
Is it possible that the slideshow, the slides could go on slideshow?
Oh, yeah.
Fantastic.
That's better.
Yeah, that's great. Yeah, thank you.
Sorry, my computer's just been a little bit slow.
Thank you, Tom.
That's where we got to. Is there any questions at all there, Bev? I just can't see the chat feed on my view, unfortunately.
I don't think we have any questions yet on the chat at this point. No.
Fabulous. I'll carry on
Thank
then.
you.
I'll say that's good news. Okay. So moving on to more specific lung conditions. So the first one I'm going to cover is COPD. Now, you may have heard of this one. It's probably the most common one that people get heard of. And just to break it all down, so the first bit word stands for chronic. So chronic is anything that's long term. It's a long standing condition. Obstructive, as you might expect, is causing a blockage. So there's something stopping you getting air out of your lungs. And we call it an obstructive lung condition because we can get the air in, but we can't get the air out. So it's an obstructive lung condition. And pulmonary, so essentially just the fancy term to say anything to do with the lungs. And disease, obviously, an illness. So it's actually an umbrella term for a number of conditions that make it difficult for you to empty air out of your lungs because they've been narrowed. The most common one that you'd see is persistent bronchitis and emphysema, which can also occur together. So bronchitis basically means that you've got inflamed, narrowed airways. So if any of you that's had quite a nasty chest infection, where you get that sore, tight feeling in your chest, you may be coughing up phlegm, that can also be an episode of bronchitis, so you get similar symptoms. And people with bronchitis often produce sputum or phlegm. The term bronchitis just relates to the terminology used inside the lungs. So you've got your main windpipe, also known as your trachea, and then when it changes into the smaller branches of the tree, they're called your right and left main bronchus, and then the smaller branches, they're then your bronchi. So inflammation and narrowing of your wind tubes there in your chest. Emphysema affects the air sacs, so those tiny sacs that we were discussing a moment ago at the ends of your lungs. The best thing to think about your alveoli or your air sacs are as bunches of grapes. So if you get a nice fresh bunch of grapes from the grocers, they're all squashed together, okay? And there's lots and lots of ripe fruit there on the ends. Unfortunately, with emphysema, what can happen is that some of those grapes break, some of them, the actual cell wall between them break down, and you end up more like oranges, so really, really big, large air sacs. Now that may sound like a good thing because you can get more air in and out, but going back to surface area that we discussed before, you're actually reducing that surface area down. The gas exchange isn't as efficient, and as a result, you get air which is trapped in the chest and very difficult to exhale. And as I said at the bottom there, this process makes the airways narrow, so the inflammation there narrows the airways. It also makes them very difficult to get air out because you've got this air trapped in the oranges that have replaced the grapes there. Okay. And the next slide hopefully makes this a little bit easier to visualize. So on the left-hand side here, you've got healthy airways, which are nice and open and round. And then you've got your airways with persistent bronchitis. So you can see there, the lining of the airway is inflamed. You've got mucus in there. So actually, the amount of air that can travel down that airway is going to be much more reduced compared to your healthy airway. And then a nice way to analyse it is a little bit like a hose pipe in the garden. If you've got a garden hose, you can get, it's clear, you can get lots and lots of water through, no problem. But if you've got a hose like the fire service use, you can get much more water through then and much quicker volume, okay? So just comparing the two there. So obviously your garden hose would be the one that's persistent bronchitis, and obviously the hose pipe for the fire service use would be nice and healthy. And similarly to do with your air sacs as well. So on the left-hand side here, you've got air sacs which are nicely densely packed together and all their cell walls are intact. On the right hand side here, you can see how the cell wall is starting to break down, so you get more like a bunch of oranges compared to a bunch of grapes there. Okay, so in summary, you get airways which are loose, which are floppy, and are prone to breaking down and repeated infection. So now that's said, what causes COPD? So COPD is usually caused by smoking. Around 80% of cases worldwide are caused by smoking. However, they can be caused by certain occupations, so exposure to fumes, dust, or they can be genetic, or they can be caused by illnesses when you're a child. Unfortunately, COPD is a progressive disease, which means that although it can be treated and managed effectively, and these days very effectively, unfortunately, it cannot be cured. There's around 1.2 million in the UK, probably slightly more now, given the date of that there. And it mostly affects people over the age of 40. If you present to your GP, they'll mainly consider COPD in those of you that are 35 and above. It usually affects more males than females, and is responsible for 5% of deaths globally, and is the 5th biggest killer in the UK. And I think actually reading the latest data on that, it's moved up to 4th now as well. So it's the biggest one that's causing the most concern, because it's the only one out of the top 5 in the UK that's actually increasing. So it's obviously one that we need to keep an eye on and hopefully manage. Okay, so moving on to asthma. So asthma is another common long-term disease. And when I'm talking about asthma here, I'm talking about adult asthma only. You can get pediatric asthma, but that's managed slightly differently. It's not something that I cover tonight or in my day job, so to speak. Similar presentation in that people that have asthma have very sensitive airways that become inflamed and tighten when they breathe in. And this can be caused by literally pretty much anything and everything. So a stimulus, whether that be dust, whether that be pollen, causes a reaction in the chest, an inflammatory reaction, and you get very tight, narrow breathing tubes. And that obviously makes it difficult to breathe, and you can't get air in and you can't get air out of the chest. Most people with asthma who receive the right treatment, which is usually steroid-based, and take your inhaler correctly, control their symptoms and lead normal lives. And again, I've put a pictorial image here to hopefully help gauge the understanding. If we go back to the hose pipe and the fire hose analogy, you can see on the left-hand side here, you've got normal airways, and that'll be the fire hose there. So you've got a large passage for the air to go through. And then someone who has asthma, so you've inhaled some form of stimulus, whether that be dust, whether that be pollen, literally anything, everything, aerosols, aftershave, deodorant. It can narrow the air passage, and that obviously makes it very, very difficult for the air to get through and causes the problems with breathing. And I'll just touch on asthma and chronic asthma, because really what we're talking about here is asthma that people have long term, but can also go into form COPD. So asthma is usually managed with drugs known as bronchodilators, and the problem with asthma that it can, unless it's managed properly, always have a little bit of inflammation in that airway, and that can become long-term asthma. The chronic inflammation can lead to excess mucus production, excess cough, and increased infection, as we said. However, because the symptoms are similar, and because people who have asthma of children can develop COPD later in life, it is really, really important that we make the distinction between asthma and COPD. If you do have any concerns with your breathing, it's really important that you do get a diagnosis, because you need to make sure actually what we're treating. Because asthma, the big difference between asthma and COPD is that asthma symptoms are fully reversible. Okay, to have asthma, it can be fully reversible. So you have normal healthy lungs, you inhale some form of stimulus, that causes the bronchospasm or the tightening in the chest. Then you have the treatment to reduce that tightening, and then you should be able to go back to normal. Whereas COPD is a progressive disease, so actually your lung function steadily gets worse. And you can manage it, and we'll talk about that in just a moment, but that will steadily get worse. So the big difference is that asthma should be fully reversible with treatment. If you have persistent asthma, and if it's particularly not well controlled, unfortunately it can turn more into a COPD element, because you've got that persistent change there in your lungs, and actually you can't reverse it fully to what it would be. Okay. So I'll talk a little bit more about support now, unless anyone's got any questions around asthma or COPD. I've just given a bit of a summary there and hopefully an insight into what each condition is. Okay. Okay, so talking on to a little bit of what we can do to support people. I've just touched on, it's really important that you as the individual own your condition and get a diagnosis. So what I mean by that is, if you are struggling with your breathing, if it's going on for a few weeks and you're really not happy, it's important that you do get checked out. And usually your first port of call is going to your GP. They'll then potentially refer you on to some tests, whether that's in the GP practice or potentially my team can do those tests, and we'll have a look at what's called your lung function and how well your airways are performing. And if we're unsure whether you have asthma or COPD, or a little bit of both potentially, what we would do is test your lung function, so ask you to blow into a machine. We can then give you a drug to open up your airways, and then repeat that test. And that way we can see whether there's any reversibility, so whether that obstruction is there all the time, regardless of whether you have medication or not, or whether actually it does get better with the treatment. And that allows us to establish whether or not you've got asthma or COPD, and you give us a picture of what's actually happening inside you. Then once you have been diagnosed with a respiratory condition, it's really, really important that you know as an individual what your normal is, and what your normal symptoms are. So by that, I mean, what is your normal? Is your normal that you can walk around the block, no problems, you get out of breath? Is your normal that you can manage, but you get breathless when you walk more than 50 meters? What's your normal symptoms on a day-to-day basis? And that will really, really help you if you do become unwell, because you can know that you're not able to do the things that you can normally do quite comfortably. Combined with that is what colour your phlegm is. Apologies for those who've just had the tea, but if your phlegm is normally quite clear and it suddenly turns to a yellow or a brown or a green, then obviously it's a nice indication there that you have got an infection. It's very clear and obvious. Okay, if you don't produce any phlegm, it's not a problem. It's just something else that's nice to know and record, so you know what your normal is. Okay. Know what your triggers are. So really important that we actually know what your triggers are. So what sets your chest off? So for asthma, some people are only affected seasonally. Some people might only get affected when pollen first comes in, so tree pollen, for example. Some people may with COPD know that they will get particularly breathless when they walk up the stairs. So they take the medication before they walk up the stairs. And finally, it's really important that we know how to self-manage and take action sooner rather than later is the biggest key there. So if you are at home and you're struggling with your breathing condition, it's really important that you recognise the signs and symptoms and take action sooner rather than later. Okay. So what I have got, which I'm hoping that I can show you now, if I stop sharing those slides, I can hopefully share a different screen with you. And I can show you a copy of a management plan. I did try and get it all on the same presentation, but I couldn't get it in big so you could all see it. So just bear with me a second and hopefully I can share this with you. Lovely. Can everyone see that management plan okay?
Yeah, that looks good.
Lovely. So this is one of our old ones actually that I pinched because it was an online copy. So this is a COPD self-management plan. So it looks at all of your normal medication. So your normal medication, what you have, how you take it, and you can circle the right inhalers that you normally take. And on the left-hand side here, you can see it gives you a guide of what to do. So if you experience 2 or more of the following symptoms for more than 24 hours, you need to look at your taking your rescue medication. So if you've got increased breathlessness, increased coughing, a change in sputum colour, or a change in sputum volume, your first port of call is to have more of your blue, so your reliever inhaler. And that's usually 9 times out of 10, it'll be this inhaler here, taken with a spacer device, ideally. You can have more of your blue inhaler and then carry on with your normal medication. But if it's going on for more than 24 hours, then it's important that you either get some support if you don't have a rescue pack at home, or that you look at starting your rescue medication. And now rescue medication is medication that's prescribed by a doctor or by one of our nurse specialists or AHP, so health professional specialists. And that's normally steroids and antibiotics if needed. And that's where it's really, really important that you know what your normal is. Okay. So if you know that your normal is that you can walk down to the local shop, pick up your paper and walk back without any problem, and you find that actually you were a bit breathless yesterday, you took more of your blue inhaler, you now walk into the shop, but you have to stop 3 times on the way because you're more breathless than normal, and you know that you're potentially having a flare-up of your airways disease and you need to take some action. And that's usually in the form of steroids and then antibiotics in case you feel like you've got an infection. And the thing to remember that people that do have a long-term condition is they're the experts really. They're the ones that can tell you whether or not they've got an infection, because they know what their normal is and they know how they feel. And it may be that the classic sign is that your phlegm changed colour, but it can also have the normal signs of infection, so a temperature as well. So really what I'm trying to say is that if you do have a long-term respiratory condition, you are diagnosed, it's really important that you're actively engaged in the management of that condition. I'm sure, Bev, you'd echo those thoughts from your diabetes service as well, that the more that you engage in your management and the more that you work with the healthcare system to support you, the better your outcome is going to be. That's just an example of a COPD, self-management plan there. And then we do have another one for asthma here as well, which again is very similar. So it looks at increasing your blue inhaler more than normal. So, you know, if needs be, you can take 2+ of your blue inhaler up to 8 times a day. But usually the blue inhaler, it's just morning and evening COPD. And sometimes with asthma, you shouldn't really need it at all. In fact, if you've got asthma, an ideal world, you shouldn't really be needing your blue inhaler at all, maybe once, twice a week. If you're needing it more than that, it might suggest you've got some underlying inflammation there that needs to be resolved. Okay. But again, it talks through what your normal is, and then obviously looks at your rescue medication there as well. Okay. And obviously step 3 is an emergency there. So the thing about asthma is it's, I wouldn't say it's more or less important than COPD, but you can deteriorate much faster with asthma. So if you're ever unsure with asthma, please don't delay and obviously seek urgent medical help in terms of 999, because it can happen very quickly and without much warning. Whereas with COPD, generally it's much more of a slower process. So you start to feel unwell maybe over 2 or 3 days before it comes to a peak and you feel like you have to get that emergency help. But hopefully, if you follow your rescue pack and follow the steps there in the guide, you won't ever get to that point. It's much more likely with asthma that you'll get to that point much quicker because of the time scale that it can tell. So that's most things there from a management point of view. My next slide is looking at inhaler techniques. Has anybody got any questions about management plans at all?
Hello, Tom. There's a pre-question that we had that I'd just like to pose now, if that's okay.
Yeah, that's fine, yeah.
Okay, so the question is, do people with COVID-19 symptoms sometimes present with a productive cough rather than a dry cough? And that's really pertaining to asthmatics.
Yeah, it's a good question. So the answer is yes. It's roughly about 1/3 of patients seem to get a productive cough. And these figures are taken from patients that have been hospitalised due to COVID. It lists all the common symptoms that were reported. So yes, it's not as common as a dry cough. So dry cough is 60%, so almost 2/3 of people report a dry cough. But a productive cough is around about 1/3, so 27% of people do report a productive cough. The thing that people are still understanding is we're still learning about COVID, and we're still learning about what symptoms present. And it is a more varied presentation. It's difficult to tell, and this is one of the troubles really in respiratory, is if you have got an underlying respiratory condition, it's very difficult to tell if it's a COVID exacerbation or if it's a flare-up of your current disease, and that's some of the difficulties that you have. So the advice there is, yes, it can, but if you are following, if it feels like a normal flare-up, then to continue with your normal self-management that you would normally do. And obviously, if it persists or you feel like it's getting worse, and that's when to seek some more attention there. So yes, it can do, although it's not as common as the dry cough. And what I would do in that situation, again, going back to each individual as the expert, is try and compare it to what a normal flare-up feels like, and see if you've got any additional symptoms, for example, such as body aches or fatigue, or sometimes people are reporting a loss of taste and smell, and try and join the dots that way. But definitely continue with your normal management should you feel like you are more short of breath. Is that okay?
That's fine. And another question, it's very similar, and it's about how easy is it to differentiate asthma symptoms from potential coronavirus symptoms?
Yeah, I mean, I'd say it's not, if I'm honest, because some of the symptoms are quite common. The guidance that's been given is to follow your normal asthma management plan. So that's increasing your reliever inhaler, potentially increasing your steroids as well. I won't talk too much in detail because it's individual prescriptions for individual people, but continue to do your normal plan. And then really it's looking at any other or unusual symptoms that you see. And then now we've got the testing available as well. It's getting that test if you are unsure. So obviously you can isolate. But yeah, they can mimic each other. And in particular in my team, we sort of took the decision that because our patients were reporting respiratory symptoms and they've not had the chance to get tested, we would protect the patient and ourselves by wearing the PPE for all of our visits, regardless or not if we've got a confirmed diagnosis. And that's just because we don't know, and they do mimic each other really. So that's some of the troubles that we have. It's very different, for example, if you have a wound on your leg or an ulcer that's particularly sore, you know if that's sore, but then that's different to having a new chest symptom. When you've already got chest symptoms, it makes it slightly more challenging.
Okay, thank you, Tom.
Thanks. Okay, so hopefully I can go back to sharing the presentation. Give me a second. Lovely. Lovely. So we'll talk a little bit more now about inhalers, and generally, and again, I'm talking general terms here because there's probably lots of people there that may have respiratory conditions in lots of different types of inhalers. But generally, in terms of inhaler types, there's two types. There's your metered dose inhaler or your aerosol inhaler. And these are ones that normally have a canister. So you can see the one on the left here, that's the most popular inhaler there, Ventolin or salbutamol. It's a metal canister that you push down and you can actually see it coming out the end. It's an aerosol. It's a little bit like if you've got an aerosol cannon you use for deodorant, you can see it coming out. And the advice with any form of those inhalers that you can see coming out the end, and this one here, the Easy Breathe, is slow and steady. Ideally, any one that you click, so this one here that you twist, or this one here that you push down, any that you can actually see the medication escaping out of the end, and you don't need to put any effort in to suck that medication in. Ideally, you should be using a spacer, which is a clear plastic tube that I showed you on the management plan earlier. And you can get those from pharmacists or GP very easily. And what that does, it allows you to take the medication a much easier way. It's actually quite difficult to breathe out fully, put the inhaler in your mouth, start breathing in, press the inhaler down, and carry on breathing in at a slow and steady rate. It's incredibly difficult to do because the medication's cold when it comes out of the chamber, and it automatically gives you a bit of a shock and you end up coughing a little bit. It winds me up a little bit when you watch programs on telly, when you see people taking inhalers, and I just think this is not right. So if you do have a metered dose inhaler, always try and use a spacer. And the idea is that you would press it into the spacer, you'd breathe out fully, and then you breathe in at a nice, slow, steady rate, okay? If you haven't got a spacer, it's not the end of the world, but the idea is that, again, you would breathe out fully, put the inhaler in your mouth, press the inhaler down, and then breathe in a nice, slow, steady pace, okay? And then try and hold your breath, ideally 10 seconds or as long as possible. Most of these inhalers will be 2 puffs. And another really good point is please don't take 2 puffs together. Don't do it together in the same breath. And if you can help it, try and separate your puffs out. So press it once, have a breath in, give it 20 or 30 seconds, and then repeat the process. The reason being, inside the little canister here, you've got the actual medication and a propellant. And if you do it too quickly, you're not giving the medication and propellant time to basically fuse together again. You're just going to get propellant second time round, so you're not getting a strong enough dose. So for anything that you can see coming out of the end, and you don't have to do any effort to get the medication out of the inhaler, it's a slow, steady breath in. And it's all to do with the molecule size. If you breathe at a nice, slow, steady pace, you get the medication right down into the base of the lungs. If you breathe in too quickly, because it's such a small molecule, it just hits the back of your throat and you can breathe and get to where it needs to be. Okay. So anything that's a reliever, like medication, and you can see the medication, it's a slow, steady breath in. And what I have done at the end of the presentation is put some links to websites where it gives you a nice video guide, so you can watch the video guides and watch how to take them correctly. Okay. It's quite tricky to do when I'm presenting, so the videos are much clearer. And the next one is a dry powder inhaler. So these are the ones where if you open the inhaler, so you either slide the covering back, you don't actually get anything come out the end of it. Okay, so these are the ones where it's a long, hard breath in. You need to suck nice and hard. So what we're saying here is breathe out again, nice tight seal around the inhaler, and it's a long, hard breath in. Okay. Lovely. I've got some videos at the end which you can have a look at in terms of inhaler technique. So unless anyone's got any specific questions about inhalers, I'm happy to move on to pulmonary rehab. Yeah. So for me, being a physio and working in the community, pulmonary rehab is the #1 thing, really. So people that do have a long-term health condition, and I'm not doing the medics any injustice here, because you can have medication to help open up those airways that have become inflamed and narrow and tight. And you can do exercises to clear your chest of any phlegm, and that will help, definitely. But the #1 thing that's going to help to improve your quality of life is to hopefully break this cycle of inactivity and give you the freedom and confidence to do more. But what tends to happen if you do have a long-term respiratory condition is you start to feel breathless. It's a horrible feeling breathless. You know, I can't imagine what it's like to have a long-term condition where you struggle and you feel breathless all the time. But when you feel breathless, you automatically feel anxious, you feel panicked, and you feel like you can't do what you used to do. And because of that, you become fearful that your activity makes you breathless. And then as a result of that, you will avoid any activities that make you breathless. And then as a result of that, you do less activity. And because you do less activity, the muscles that you normally do, that normally use, become weaker. So the example of that is, if you can normally walk to the shops, if you've been in hospital with a flare-up of your airways disease, a bit more breathless, the next time you try and walk to the shops, you might find it takes you longer. You have to walk slower, or you have to take a couple of breaks on the way. And that's because you haven't used your muscles, they become weaker. So the muscle size decreases. And weaker muscles use more oxygen and are less efficient. Okay, so that's one of the issues that you have there. And unfortunately, it can happen really quickly. It's the old saying, if you don't use it, you lose it. And certainly after a week off Joe Wicks, I fully appreciate that one. But you feel breathless. And because you feel breathless, you feel like you can't do what you used to do. And that may be simple things around the house. The classic one is people doing the hoovering or doing the tidying up, or walking to the corner shop. But the worrying thing is that if you don't try and break this cycle at some point, your actual world gets smaller, because you can't do the things that you used to do because of your breathing. And it comes to the point where actually you're needing support with quite a lot of activities. And that then leads on to secondary health complications as well. So where pulmonary rehab comes in is we actually help you to do more to reduce breathlessness. So in terms of the program that we run, it's 6 weeks, and it's twice a week for 6 weeks. And I'll talk through this diagram in a moment, but the idea of it is essentially is to give you the confidence to exercise. And it sounds like we've gone mad, to be honest. So people are already breathless. People are breathless washing and dressing. People are breathless walking from the car park into the building. But then you want them to exercise where they'll be more breathless. It sounds like we've lost the plot. But the idea is actually that we give people the confidence and the knowledge to regain that control of their disease and to own it. And the downward spiral that we just talked about only starts to happen when people feel that they're not in control of their disease and they don't own it. So what we do in pulmonary rehab, and it's up and down the country, and I'm just giving a bit of a plug to our service really, is that we work really, really hard with you to explain that you will be breathless when you exercise, but it's important that you do exercise in a certain range, and we use a breathlessness score to determine the level at which people should exercise. The muscles become stronger, strong muscles use less oxygen, and therefore when you're doing tasks that you used to find quite easy, quite difficult, you find that soon actually they're getting easier for you. So for example, if you used to find doing the vacuum unit really difficult, pulmonary rehab can help you do that much quicker and also much easier as well, because you're stronger, and because you're stronger you're less breathless and your tasks become easier. And as a result of that, you feel better and you feel more motivated to continue with your daily life, and that really is the key. What we can do to support you. Yes, we can help you do inhalers, and that's really important. Yes, it's really important you have a management plan when things go wrong, but the number one thing, and the take-home message really, is that actually if you have got a long-term respiratory condition, the most important thing is that you own it, so that you feel like you're in control, you know what to do when it goes wrong, and you know how to improve your quality of life and your strength. And that's the key really from the presentation today, that actually, yes, unfortunately, if you do have a chronic condition, we can't take it away. What we can do is really help you to manage those symptoms. And if anyone is struggling or is fearful or is worried, I'd definitely suggest that you speak to either your GP or your practice nurse. Or if you're known to ourselves already, we can hopefully support you with that. So I've just got a few useful links on the end here. The British Lung Foundation, the top one, is very useful. Nice advice on there, really sort of plain English advice as well, and really nice links to support groups as well, which is really good. The second link from Asthma UK is really useful inhaler technique videos. And then Right Breathe, more for healthcare professional use really, but again, it's got some sort of slightly higher level information on there, which is really, really useful. I think that's most things from me. Again, time to take some questions, and I have got a little bit more advice on breathing exercises, but I think one of the questions was asking about breathing exercises as well. So thank you all for your time. I hope you're all still with me and not nodded off there, but yeah, I hope that was useful, and yeah, thanks for listening.
Okay, Tom, there's a few more questions. One of them you've kind of answered already from your presentation, and particularly when you talked about the pulmonary rehab. So the question was, should someone with asthma be taking daily exercise? Because the advice is confusing, but I think you've gone over some of that already.
Yeah, it's a good question, because obviously the advice is to self-isolate. What I would say, as all these questions, it depends on the individual, and it depends on the severity of the asthma. So if you've been told that you have to shield, and you've had a letter from your GP, then obviously I wouldn't go against that advice. But if your asthma is normally well controlled, and you've got a nice plan in place to control your asthma, and you normally function without any problems, so you're not you're not going to hospital regularly, you're not on lots of steroids, then I don't see any reason why you couldn't exercise, obviously adhering to the current social distancing guidelines.
Okay, thank you. Another question from Ronald Brown. Have you got any extra tips for individuals who are asthmatics who have to go to work during this time?
Yeah, it's a really good question. This is one that I actually put to Dr. Ramachandran today. And again, it goes back to the severity of the asthma again, really. So if your asthma is well controlled, and you're not having lots of flare-ups, and you're not having to go to hospital regularly, if you've got stable therapy with your reliever, so normally your blue inhaler and your steroid inhaler, and you're taking that well, and you don't need to shield, and obviously the guidance is that you can continue to go to work. However, what I would say about that is it depends on the job that you do as well. And definitely in the trust where I work, and I'm sure if you're an employee, you've been given or you've been advised to complete a risk assessment, and that will assess your ability to do your current job. So sound like a politician here, but it depends on the severity of your disease and the job that you do. And what I would say, if your asthma is quite stable and you feel like you can socially distance fairly well with your job, there should be no reason why you couldn't return to work. Some of the other things that are out there that you can do is a lot of the common sense stuff, if I'm honest, and it sounds a bit daft, but the regular hand hygiene, really important. Trying not to touch your face or your nose when you're at work, really important. And just being sort of sensible. If you can, as the government guidance suggests, avoiding public transport if at all possible. Just thinking about those aspects as well. And again, depending on your job, it's worth having a chat to your employer, and can you work from home if needs be. That would be my suggestions really there. And the simple things as well. So making sure that you carry your reliever medication with you. So whatever you take to relieve your symptoms, carry that with you at all times. And particularly in asthma, those that have asthma will know that one of the things you can do is to track your symptoms with a peak flow diary. So if you are concerned and you want to keep an eye on your symptoms, you can do a peak flow diary as well. And what that will do is obviously track your asthma symptoms, see how you're doing there. That's pretty much most things. In terms of masks, I'm a little bit sitting on the fence really. The general advice that Dr. Altrange and I were discussing earlier is that a surgical mask or a hospital mask that you see wouldn't be much useful. But if people have got the cloth masks that you can see or some have been made, they can be quite useful. But they're a little bit of a double-edged sword because they can feel quite restrictive, especially if you've got a respiratory condition. And also you are naturally touching your face more when you're wearing one. So in a nutshell, it would be dependent upon the severity of the asthma, the job that you do, and obviously any risk assessments that go with that job. Okay,
and just a couple for me. This one was from Ellie J. Campbell, and the question is, what would you suggest to alleviate the symptoms of congested lungs?
And this is a good question as well. So again, it will go back to what's the underlying cause of the congested lungs. If it is due to sputum, due to a COPD, for example, then I've got some nice slides actually that I don't mind running through if we've got time to go through some airway clearance techniques. I can run through those. It may be helpful if you've already got airway clearance techniques or maybe a device to help you clear your lungs and it's still, you feel like you've got your phlegm stuck there. That you could try going back to your GP about what we call mucolytics, so medication to try and break down any of that sticky, tenacious phlegm that you can't shift. And also, again, it sounds a bit silly, but think about hydration. Really, really important. If you're dehydrated, it's very difficult to clear your phlegm because your phlegm becomes quite thick and sticky. But keep yourself hydrated as much as possible. At least looking at 1.5, if not more, 2 litres of water a day, ideally as a minimum, just to keep yourself topped up and hydrated, and that will help you to clear your chest. I have got some slides if we've got time, but that's relating to phlegm. The other issue is it could not be related to your chest. So if you do feel like you're congested and you can't bring anything up and you're more breathless than normal, my advice would be get checked out because it could be related to your heart, for example. Not to scare anyone, but just to get checked out and make sure that actually, we're treating what we think it is there. But if you have got a diagnosis of COPD, you do feel like you've got extra phlegm on your chest, then yeah, some breathing exercises really will help. Keeping hydrated, and then if that still doesn't help, you can obviously have a look at any medication to help loosen that phlegm on your chest.
Thank you, Tom. We can look at those slides at the end if we get a chance to do that. And just one more question from me, and I think it's along the mask theme. So, can wearing a mask help to protect you from pollen in relation to hay fever?
It's an interesting one, and I guess you're not breathing the stimulus in, so yes, it can. But what I would say with hay fever is you're going to kind of have to wear your mask all the time, or not have any doors or windows open. So it's a bit tricky with that one. if you know that pollen sets off your asthma, and it's like a seasonal pattern, then my advice would be prepared, because you can still, if you know it comes on year, get prepared for it, speak to your doctor, make sure you've got an inhaler ready to go, and then the antihistamines that you might need. But it can do when you go out and about. So if you have to go out and about and it is that season, yes, wearing a mask can help, because you're not directly breathing in those particles.
Okay, thank you very much, Tom. There's a few questions that came in as you were talking, so I'll pass you on to Donna for those questions.
Okay, thanks.
Okay, good evening, Tom, and thank you so much for your presentation so far. One of the questions is, do masks promote bacteria escalation back into your lungs? And can wearing one actually make things worse?
And this again is a difficult one to answer, really, because in hospital, for example, using the hospital surgical mask, the actual idea of those masks is to protect anyone else from you. So, for example, if you're a surgeon doing a procedure, you're protecting the patient from you as the person. So if you're wearing one of those all day and they get moist, then yeah, they can cause bacteria to retain in that area, because you've got damp, wet environment which bacteria love. So that can cause a problem. The actual material ones are slightly better. So that what I would say is, if you're going to wear one, the potential material one would be better, because just stopping the virus, and it shouldn't get as wet as a paper mask would. So they can make it worse. The government guidance at the moment says to not wear one in public, and I think what they're looking at is the social distancing. So if what I'm saying to my staff at the moment is, if we are in a patient's home and we're within 2 meters, then we would wear a mask. But if we're more than 2 meters away, there's no need to wear that mask. So it's thinking about when you wear one and what you wear one for. So if you're in your own car by yourself, then I wouldn't say there's any need to wear a mask, because there's no one there. You're not at risk of any virus there. But if you did feel more comfortable wearing one when you go to the supermarket, for example, that might be an opportunity where you would wear one, but then take it off once you get back in your own car or your own environment.
Okay, thank you. And sticking with you, another question is, how often do we...
Sorry, I lost you there. Sorry, could you mind repeating that one? Sorry.
How often do you need to be changing masks?
Yeah, and another interesting one, and it's a difficult one. And I think actually, if you look at the research there's not an awful lot to guide us. Certainly in the healthcare world and acute hospitals, you're looking at the cohort of patients there. So normal, they call them fluid shields, so the typical surgical mask that you might see on telly, the loose fitting ones. They would change them once they go in and out of that patient area. So if you've got a bay of 4 people with suspected COVID in hospital, the nurse or healthcare professional would keep that mask on whilst they're in that area, and then they would leave it they would take the mask off once they leave and put a new one on. So in terms of take one on and off, I think it would depend what you're doing. So as I said before, the previous example, if you're in your own environment, there'd be no need to wear one, and then you try and limit your contact in a dangerous environment such as the supermarket with lots of people around to short time period as possible, and then take it off afterwards. Because they're a bit of a double-edged sword, as I said before, because if you're not used to wearing one, if you've got a respiratory disease, they can feel quite claustrophobic. You're tempted to touch your face more, and that's a bit of a problem, because obviously you're putting your hands near your nose or your mouth, where you've got a risk of transmitting the virus. So it's personal preference, and I know they are being used in other countries at the moment, but as we say at the moment, they're not currently being used. But I think it's trying to be mindful of those social distancing reasons, really, and staying that 2 meters away, would be my advice at the moment.
Okay, thank you. Moving on, are there any stats re respiratory conditions and the BAME community?
In terms of for like long-term respiratory conditions, so COPD and asthma.
Yeah.
It's a good question, and I was looking at this, and in terms of stats, I haven't sort of looked at any objective evidence, but from my own clinical experience of 10 years plus, there doesn't really appear to be any link or any theme, especially not for COPD and asthma that I'm most involved in. You know, it's potentially more obvious in other conditions. So sickle cell, for example, that's definitely got a link. But for COPD in particular, because its predominant cause is smoking, you know, that can anyone who smokes from any background really. No, I haven't seen any links myself. The only one that I touched upon was the link that's being investigated at the moment with COVID and the increased prevalence in the BAME community. And there's obviously potentially multiple reasons why that is. And I think obviously we'll learn a lot more from this episode and from the investigation.
Lovely, thank you. Another question that we've received is, what does traces of blood in your sputum indicate?
Okay. Again, talking generically here, and we need to know about the individual case. What I would say is if you are coughing up frank blood, so what we call frank hemoptysis, so lots of blood, and you'd notice it'd be lots of blood, then that's a need to go and see your GP sooner rather than later. Traces of blood, so what we call streaking, it could be caused from trauma. So if you've got a particularly nasty cough, so a chest infection, you've been coughing all day, you can get sort of slight trauma to the back of the airway there. And that's more than likely what it is if you have been coughing a lot. It's still important that you get it checked out though, especially if it's a new symptom, because it can also be caused by some medication as well. So if you've changed your inhaler or if you've changed some form of medication, that can cause slight irritation of the airways as well. So what I would say, if there's a reason for it, so you've got a particularly nasty cough and you've been coughing all day, and at the end of the day you've got slightly blood-streaked sputum, and it could be caused from local trauma. But if you're getting it regularly and you've changed medication, or it's a completely new symptom, then definitely seek medical advice. And if you are unsure, obviously always speak to your GP to get checked out, because you need to make sure that you investigate any causes of that. But if it's streaking and you have got an underlying health condition, it can be that you've done lots of coughing. What I would say to that, being a physio, is there's lots of other techniques that we can show you to help you clear your chest, which potentially are less traumatic, so you're not getting the soreness in the throat there.
Thank you. My final question is from somebody that says, if I have asthma and get COVID-19 symptoms and I'm more breathless, should I increase the amount of times I take my inhalers? And are there any breathing exercises I can do?
So in answer to the question, I'd go back to the individual there and their management plan. So you should follow your management plan and increase your inhaled medication as per your plan. So whatever it dictates in your plan, which is usually increasing your reliever inhaler and your steroid inhaler. The reason I can't really be more specific is because some people have their steroid inhaler as their reliever and their maintenance therapy, and they step up that inhaler rather than stepping up just their reliever. But in that instance, if you're asthmatic and you do feel more breathless due to COVID, then follow the steps in your plan, in your asthma management plan. You can look at obviously increasing any support that you might need. So if you are worried and you have a specialist nurse that looks after you, a GP, speak to them about it. But essentially, you would follow the plan that's stepped out in your asthma guide and your asthma management plan. So you could increase your steroid and you could increase your reliever medication, but it would depend on what's in your plan. So the answer is yes, you can, yes, you should, but I would follow what's in your asthma plan.
Okay, thank you. We've got one request that we can do a little bit later for the last slide with the websites, etc., if they can be shown again so people can take the details from them. But if you want to get your slides, you had those ending slides that you might want to show.
Oh yeah, sure, just bear with me one moment.
Thank you.
Okay, so hopefully everyone can see that okay. There we go. So this is what we call active cycle of breathing. Generally, your respiratory physiotherapist or specialist nurse will go through this with you. And it starts off with nice, relaxed, gentle breathing. I've got a nice picture here of what diaphragmatic breathing is. You don't have to be lying down, but essentially what the idea is, you can have a go at it now if you want to do it together if you want to. If you put your left hand on top of your chest here, your right hand on your tummy, and just try and breathe normally. What you should feel, if you're nice and relaxed and sitting at rest, is as you breathe in, your top hand, your left hand barely moves, but your bottom hand, your right hand is going up and down on your tummy as you're breathing in, nice and relaxed. And the idea is, some people with a long-term breathing respiratory condition, you breathe quite fast and you tend to cheat a little bit and use the muscles in your neck here to get every ounce of air into your chest. The idea is that you find a nice quiet spot, whether that's lying down, whether that's leaning forward, whether that's standing up, leaning on a table. One hand on your top of your chest, one hand on your tummy, so your right hand on your tummy. You try and breathe in nice and slowly, in through your nose, out through your mouth. The idea is that your top hand, your left hand stays nice and still, and your bottom hand, you can feel that going up and down. And that's just nicely controlling your breathing. So we call that breathing control or diaphragmatic breathing. So you're breathing nice and controlled manner and using that big muscle, your diaphragm muscle, rather than straining using these muscles here. You get more air into your chest. Then you would take 3 or 4 big deep breaths. So big breath in as big as you can. Hold it for a couple of seconds, 2 or 3 seconds, and breathe out. And you do that 3 or 4 times, and then you go back to your nice relaxed breathing there. And again, you do 3 or 4 deep breaths with a 3-second hold, and then your nice relaxed breathing. And then finally 3 or 4 deep breaths with a 3-second hold. And then once you've done that, you do a technique called the huff, and I've touched on it a little bit earlier. If you do find you're getting a sore throat and you're coughing, you can't clear that chest, the huff is very similar to a cough, but the best way to describe it is if you wear glasses, when you breathe out to clean your glasses, so you know when you go on your glasses, or if you're cleaning a mirror or polishing the silver, when you sort of use your breath to make a little mist and then you wipe it away. That's the best way to do it, and it's quite forceful. So the idea is you take a big breath in and like that. So I'll do it again out my hand there. So it's open mouth, and the idea is that you're clearing your chest by squeezing the airways and bring that phlegm up to clear your chest. And you can do that 2 or 3 times and then repeat the cycle as much as you need to. You can do that as well with some adjuncts. So sometimes people have different devices. So an aerobica potentially is one device, a cappella or a flutter. There are a couple of devices. And what you do, you blow out against them, and it provides a little bit of resistance and a little bit of oscillation to help clear that your chest there. I'll just flip down to this slide here. This hopefully gives you a little bit of an idea of the optimum way of clearing your chest if you do have a long-term respiratory condition and you have phlegm that you need to clear. So first of all, take your reliever, so whether that's your inhaler or your nebulizer, and if you can, wait 10 to 15 minutes, have a little bit of a break. And then you would clear your chest using the exercises that I've just gone through and your device, so whether that's an aerobica, a cappella, and don't worry if you never heard of those. If you haven't got them and your chest is nice and clear, then don't worry. But if you do feel like you've got lots of phlegm and you're struggling to clear it, it might be worth speaking to your GP or practice nurse about those devices or medication. And then the idea is once you've cleared your chest, you then take your preventer medication, so your steroid inhaler. So you've opened your airways up, you've cleared any phlegm that are there, and then you can then take your medication, which is going to stop those airways becoming narrow and tight, and the medication can get to where it needs to be. And typically we suggest doing this twice daily. So first thing in the morning and last thing at night. First thing in the morning, because generally in the morning, you might find that you cough anyway, regardless of whether you've got an underlying respiratory condition, and that could be because you've been lying flat all night and not really been taking deep breaths, and it's just clearing your throat, clearing your chest. But if you have got a long-term respiratory condition, you'll probably find that you will cough quite a lot in the morning. And again, it's positional. You've been lying flat in bed, you haven't been able to clear your chest, and there's some phlegm sitting there that needs to be cleared. So it's just doing it in first thing in the morning, set you up for the day, and then last thing in the evening to make sure that you can sleep at night. Because when you lie down, you'll probably find then that you start feeling that phlegm on your chest. It's difficult for you to breathe. That's just a bit of a, if you like, a summary of what we would teach patients to do, either in hospital or in the community, if they are struggling with respiratory clearance. There is other options as well, so medication to help loosen those secretions, and also making sure that you're nice and hydrated and make sure that phlegm's nice and clear and easy to, nice and loose and easy to bring up. So I'll put them on the end of the presentation, just in case anyone wants to have a look at them later.
Thank you for that, Tom. I'm going to hand over to Doreen.
Thank you very much, Donna. Tom, we're really grateful for you coming and spending the time that you have spent with us and going through what you've gone through. It was really useful the way that you talked about coronavirus and how it can cause the upper respiratory tract infection and also pneumonia, with the upper respiratory tract infection being the lesser problematic of the two. And also about chronic obstructive pulmonary disease and how sufferers can have problems with actually getting the air out. And that's a progressive disorder, whereas asthma is irreversible, particularly where people take their inhalers and follow their treatment plan. I also appreciated what you said about people individualising and owning their asthma or their chronic problem, because that's going to help them with the treatment. And I think that was a really important message. And also about the airway clearance as well that you talked about. And it's really important to have those messages at this time, particularly with the times with the COVID-19 issues that we are living with currently. So thank you very much, and God bless you for that. That was wonderful. And what I'm going to do now is just hand back to Bev.
No, thank you, and thanks for the opportunity. I wasn't quite sure what you wanted, so hopefully everyone found it useful and it's a good resource. Bev's got my email address, so if we do have any follow-up questions, not a problem, I can get back to you on email. Or if you want any further questions or any other topics you want me to go over, that's absolutely fine. I will send these to you, Bev, okay, these slides, so you can tweak them. I'm not sure if I did in the final bit on the one that I've sent you, so I'll just resend you the final copy if that's okay.
Absolutely fine, thank you.
You're welcome.
Thank you, and thank you for giving up the time to join us this evening, Tom. Really appreciate it. And thank you, Doreen, for doing that really succinct summing up. That was great. I'm going to take the opportunity at this point to ask Dr. Sonny Kelsey Lillico. I don't know, Mark, if you could unmute Dr. Sonny Kelsey Lillico for me. Because I know we've got the mute on for everyone, haven't we?
Yes, Bev, I'm now unmuted. Can you hear me?
Oh, fantastic. So I've been texting or messaging privately. Dr. Sonny is a colleague from BCHC, and Dr. Sonny will be delivering a seminar for us, I believe, on the 5th of June. And I just wanted her to say hello, actually, and just a little snippet. I know we haven't spoken yet. Is that okay, Dr. Sonny?
It's absolutely fine, Bev. And I always say to you, just call me Sonny. Thank you ever so for asking me to support the ASH Foundation. What my intention is on the 5th of June is to really do a session to reflect on the fact that currently there are so many uncertainties and so many unknowns, and this can be quite unsettling and scary for us. But we all have so many different skills and experiences, and we respond so differently to the joys and challenges in life. So being kind to ourselves and each other is always important, but it is even more so now. So I would love to share with you some thoughts around how we support ourselves and each other to stay not only physically well, but emotionally well. So I look forward to seeing as many of you there as possible on the 5th of June.
Thank you for that, Sonny. Thank you. I've also got another colleague, or Tom and I have got another colleague, and Sister Doreen. We're all BCHC individuals. Dr. Malik, I'm going to unmute you. I think I can. Dr. Malik, are you there?
Yeah, I'm here, yeah.
Fantastic. Dr. Malik is my immediate colleague. We work in the same service, and you'll be hearing from Dr. Malik next week. Would you like just to give us a quick snippet regarding your session next week, Dr. Malik?
I think it will be more around COVID and diabetes, but also we will cover some other aspects of diabetes as well. More importantly, I think if there are any questions, which I hope it will be the same audience, they can share with you, and I can build my talk on what the audience needs. So I can prepare the talk around that. But it will be mostly around the current situation, how the person with diabetes can manage their diabetes more appropriately and safely.
Fantastic, thank you. So everyone that's listening, if you could send in those questions as soon as possible, so we can actually forward those to Dr. Malik. And also next week, we'll be joined by Angela Thomas, who's an advanced diabetes specialist nurse. And I'm hoping that we might be joined as well by an expert patient who does a lot of work with Diabetes UK. So that's a bit of a plug for next week. So I've done that plug, Pastor Donna, for next week now. And at this point, I mentioned earlier that Dr. Justin Varney has sent us an update following the change in recommendations from the government. Now, bear with me while I try and share my screen. Hopefully I'll get this right. Now, I'm trying to go to view slideshow.
F5.
Is that the first slide? Can you see?
Press F5.
Press F5, thank you, Mark. Nothing's changed. Let me just try that again. You can tell that I'm not a technical person. Okay, so I'm trying to read these as well, so let me hide that. Fantastic. So this is from Dr. Justin Varney, and before I start to read them, I hope he'll listen to this video at some point, because I just really want to thank him for sending these through. I emailed him at short notice, and an out of office came back to say that he was on a day off. And then when I looked 2 hours later, he had actually sent through this information. So really appreciate him doing that for us. So the first update is to stay alert. I'll just read through it very quickly. As we start to very slowly relax lockdown, it is important we all stay alert and prevent the spread of the virus. We can all help control the virus if we all stay alert. So this means that you must stay at home as much as possible. Work from home if you can. Limit contact with other people. Keep your distance if you are out 2 meters apart where possible. Wash your hands regularly. And do not leave home if you or anyone in your household has symptoms. Next, relating to work. If you can work from home, then continue to work from home. If you are asked to return to work by your employer, then they should be sharing with you a clear risk assessment and explain how they are going to keep you safe. This should include an individual risk assessment, and Tom's mentioned that already, element, especially for those who are vulnerable because of age, long-term condition like diabetes or high blood pressure, and should include consideration of how you get to work as well as what you do in work. The shielded group remains shielded until the end of June, and managers should be talking to staff who are shielded about how to support them. In terms of home, you can now go out for more than an hour to exercise each day, but when you are out, you must keep a 2-metre distance at all times and keep washing your hands. You can meet one person from another household outside for a conversation, as long as you are 2 metres apart. This is a one-to-one conversation and not to be in groups. You can play sports like tennis or football outside with members of the house that you live with, but not with people who live in another house. For example, do not play with your friends. And then in terms of health and face masks, which we have touched on today, if you have a health condition like diabetes or high blood pressure or kidney disease or other long-term condition, you need to be more careful. This means looking after yourself and your health, eating properly, exercising every day, and making sure you are taking your medication. It also means being more alert when you go outside and keeping that 2-metre distance at all times. Public Health England has recommended that everyone starts to take over-the-counter vitamin D supplements to reduce the risk of deficiency because of staying indoors. The evidence base of vitamin D and COVID is still not conclusive. However, it is important for other reasons, hence the recommendation. This will not be prescribed by the NHS, however. And we spoke about vitamin D in Yvette Besley's session on week 1 of these seminars. And in terms of face masks, so the government, they've recommended the public wearing a fabric face mask when going into confined public spaces. For example, when you're shopping or traveling on public transport or in a taxi. There are instructions on how you can make your own fabric mask from an old t-shirt or sock on the Birmingham BBC website, beg your pardon. So that was Dr. Justin Varney's update for us on the back of the information that came out last Sunday from the government. So we've almost come to the end of the 3rd Friday Focus seminar with Ash Foundation and everyone that we've collaborated with. And at this point, I am going to ask Pastor Donna to give a vote of thanks and close out in prayer. And at the end, we are going to show a couple of clips, and I think Pastor Donna will speak about those 2 clips that we will show. Thank you, Pastor Donna.
Thank you, Bev, and thank you everyone for joining us this evening. Bev, thanks for your continuous efforts in organising our speakers and these weekly seminars. They're going really, really well. And thank you also to Ash Foundation members for your contributions and the working together that we're all doing. Brothers Steve and Mark, our technicians and hosts for our Zoom webinars, thank you both for giving your time to support us. Thank you also again to Tom for sharing your knowledge and practice tips which will help our listeners who experience respiratory difficulties. And it's also useful to know about the anatomy of our lungs and breathing, and the self-management plan was very useful. The active cycle of breathing, I did try that myself. And thank you to everyone who has joined us this evening, and we trust that the presentation has been useful to you, and please post any feedback you may have, or you may wish to give any comments on the chat facility. We do read them all. We've heard about next week's seminar and how that will be on diabetes and chronic kidney disease, so please join us on Friday the 22nd of May at 7:15. So I am going to close in prayer, and then we're going to have 2 short clips, one with the hand washing techniques and one with the BME actors who did a 2-minute video kind of reminding us all of the importance to follow the government guidelines. But please note that this was before the recent change in advice last Sunday. So we'll be playing those 2. And at the end of those 2, we'll keep the Zoom running for about 10 minutes. So if there are any additional comments that anybody wants to make, please do so at that time. So join with me as I pray. Almighty God, giver of life, we thank you today for your love, your grace, and your faithfulness to us. We bless you for this evening session, and we thank you for Tom. And we pray, God, that you'll continue to be with him and bless him as he continues to do such good work within the NHS. We thank you for the other NH colleagues that have joined us and who will be joining us in future seminars. And we pray, God, that you will continue to protect them as they do their work. We bless you for Ash Foundation, and we thank you for everyone that's working together with the Foundation to provide these information sessions to our community, to our brethren, to our friends. And I pray for all of us, Lord, that during this time that we're going through, some of us remaining at home, not able to go out, but you're always with us, and we're so grateful, Lord, that you will never leave us nor forsake us. And so as we close our session this evening, we pray, Lord, that you will continue to be with us and you will continue to guide, protect us, and as we go about what we do, we will be safe in your arms. We look to you and we give you thanks. In Jesus' name, amen.
Amen.
So if we can have those 2 videos, Mark and Steve, please.
Go ahead, Mark.
Steve, can you share, Steve?
Okay, while we're waiting, are there any comments that anybody wishes to make? Can we unmute at this time?
Black light activated low.
Carry on, Steve. Are you able to share that, Steve? Or?
Are we able to show those clips or?
I was going to try. Should I have a go? I'm not the best.
Okay, if you would.
I'm not the best technician, but I will have a go. Is somebody please?
Lotion that you put on your hands. The glow germ light works by the use of black light activated lotion that you put on your hands, and it's used to simulate bacteria or germs. When you put your hands under the light, once you put that lotion on, it looks like what real bacteria could look like on your hands. Then the lotion washes off, and you're able to then go back under the black light to see how well you've done by washing off those pretend germs.
Okay,
Did everybody see that?
Yes, we did.
Oh, fantastic. I wasn't sure. That is really important. We thought it was important to show that, because I've got some accompanying music. Is that me? Just bear with me. Okay. I didn't stop the video from playing. It's very important. 20 seconds. It's quite a long time, really. And I would also advise to invest in some nice moisturizer, because if you're like me, you're washing your hands very, very frequently. So we should be washing our hands before we touch anything to eat or drink. If you're taking medication, wash your hands before your medication, after your medication. When you go out, when you come back in after you've been out, you should be washing your hands. Just continuously wash your hands and you know, avoid touching your face. There was another clip that we wanted to show, and just bear with me to see whether or not I'm going to be in a position to do that. I'm going to try my best if I can find. Okay, just bear with me.
Lorna, Steve is showing it.
Is Steve going to show the other video? Oh, fantastic. It's quite low on the sound.
We are all at risk from this disease. Safeguard not just yourselves, but our family and friends. Stay back. We're simple, clear, and more importantly, effective. Want to go out for food, health reasons, or essential work? Stay 2 meters away from other people. Wash your hands as soon as you get home. Look at your feet. And wipe that step. Do not meet with others you don't live with, not even family or friends. Please follow the government advice. Safeguard not just yourself, but family and friends, and your community. From this silence. If you have any symptoms, a high temperature, or you need continuous cough, still have symptoms after 7 days, get advice from NHS 111. Oh, nice. Especially yours. Stay home. Stop the spread of COVID-19.
Fantastic, thank you. And that brings us to a close. So thank you very much. Good night. God bless everyone. Keep looking after yourselves and each other, and we will see you, God willing, next week, Friday, 7:15, for the 4th Friday Focus Seminar. Thank you. The seminar Zoom will be open for the next 10 minutes, and everybody will be unmuted. So if you want